also served as a co-director of the Sick Kids Center for Global Child Health. He's also the founding director of the Institute for Global Health and Development at the Aachen University. With over 1,350 publications and over 150 book chapters, and numerous prestigious awards, and few of them I will mention: the Canada 150 Medal, the Henry Friesen Prize, the John Durst Canada Gairdner Global Health Award, and Medal from Swedish Society of Medicine. Dr. Bhutta's work has significantly impacted global health, particularly in the low and the middle income countries. His remarkable achievements have also been recognized by the government of Pakistan, which has honored him with Tamgha Imtiaz, the president of Pakistan Pride of Performance, and most recently the Sitar Imtiaz for his outstanding contribution to science and education. Today, Dr. Bhutta will share his insights on the sustainable development goals for maternal and child health in Pakistan, and a topic of immense importance to all of us. So please join me in welcoming Dr. Zulfiqar Bhutta.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you so much for the generous introduction. And I'm a little surprised, actually. I mean, I thought you should be very proud of what you have achieved today. Not just the turnout, but the fact that for a brand new organization to get off to such a flying start, despite the fact that there are sometimes misgivings, people are not very clear about what they want in a new organization. I think this has been an extraordinary start. And there is space in this tent for everybody. So I think this whole notion, if I may say, where is Ashfaq? This whole notion of this being a threat to anybody, any other organization, should be dispelled, because there is space, I think, in Canada for an organization to represent Canadians, Canadian physicians, their families, their interests, the diaspora at large. And it should very much be a partnership, if any, with any other umbrella organization that exists in North America. So I think if I had any role to play, and I don't, but I'll speak to the new elected president of APPIC yesterday, Baba Rao, to say these two organizations should work in tandem, hand in hand. But nobody can speak for Canadian physicians who are not based in Canada. This was something very clearly articulated to me by our outgoing High Commissioner, who said he doesn't know who to speak to about Canadian interests in Canada for Pakistani physicians. And importantly, not just physicians here, importantly, young people who want to come here to train. Did you mention about somebody who couldn't get a visa? Who mentioned? Right, Haris did. Thank you, Haris. The most influential organization in North America to help expedite visas for trainees is APPIC. And yet we have nobody who can speak for anybody who even needs to come in for an interview or for an appointment here. So I think there is a room and scope for doing anything. I'm also grateful for the opportunity to speak to you about a topic that I don't speak on very often, and at least not to an audience as informed as this. I've brought you a lot of materials, so there's stuff at the back that you please feel free to help yourself to. And that's not just for you, it's for your children and your families also, in terms of young people understanding to some extent what are our challenges and opportunities in Pakistan. So I want to start with declarations of interests. I have no commercial declarations of interests. I've had the great opportunity of working in many positions, both in Pakistan and elsewhere globally. So I know a little bit about what I'm going to talk about. I have no relevant conflicts of interest, and the views that I will express over the next 40 minutes are entirely personal, actually, so they don't represent any institutional position. I speak to you as an individual, but the work is always collective. So I want to absolutely at the outset acknowledge the enormous contribution that generations of students, trainees, both in Pakistan and in Canada, have played in a lot of the work that I will share with you. And many of these people have been working with me for decades, actually. What I'll cover is the background and context of the SDGs, Sustainable Development Goals. What are they? How did they begin? What do they represent? What are the key health and health-related sustainable development goals? What are the challenges to SDGs in Pakistan? And what are the opportunities? And I think the opportunities are more important than the challenges that we face. I will take the opportunity of talking a little bit about governance and democracy in the context of health and development. And finally, I will leave you with some personal thoughts of what can APPIC do in this space. And there is a lot more that can be done by the diaspora, by the Pakistani community, but APPIC has a role that I will cover. So let me start on this with a historic look back to about a quarter century ago. And this is indeed a historic photograph. This is September 2000, an assembly of close to around 120 global leaders in New York at the first Millennium Summit, which was focused on children, actually. This was the UN Millennium Summit, and this is a historic photograph because who do you see in this photograph? You see people who are at loggerheads today. You see Putin, you see the American president standing there, you see Fidel Castro, you see Yasser Arafat, you see Ehud Barak, you see Musharraf, and you see the Indian president represented there. So everybody got there, and you will almost never see an image of global leaders with Fidel Castro in this midst. So this was a historic summit which assembled to set the world for the first time 8 global targets. These were the Millennium Development Goals that were to be achieved by the year 2015. अभी सन 2000 की बात है. Those global targets were all around eliminating extreme poverty and, not too surprisingly, addressing the 2 big global challenges of maternal and child survival. Goal 4, which was related to child survival, explicitly talked about reducing preventable child mortality by 2/3 by the year 2015, and maternal mortality, which is a rarer event, by 3/4 by the year 2015. I was a member of one of the subcommittees, probably his youngest member at that time, which set some of these targets. And I can tell you they were all plucked out of thin air. Nobody had the data, nobody had the information, but they were plucked as aspirational goals. And particularly the child survival goal was thought to be potentially achievable by the middle of the century, but let's put down 2015. Now, what happened over the next 15 years was nothing short of miraculous. And if you look at the progress worldwide in reducing maternal and child mortality rates came down from 10 million preventable under 5 deaths in the year 2000 to just around 5 million deaths by the year 2015. This is the fastest rate of reduction of child mortality in the history of the world. And it happened because there was a global compact. It happened that the global compact also translated into a lot of activities in countries which set themselves a target for doing this. Some things did not go as well as others, notably newborn mortality was not as fast as child mortality, but still overall, if you look at the numbers, we were able to achieve around 3% annual rate of reduction in newborn mortality. So by all measures, the Millennium Development Goals were a phenomenal success because they aligned the world around some aspirational goals that made sense to low and middle income countries. So when it came to September 2015, and a couple of years before, when the UN Secretary General Ban Ki-moon started looking at this, they said, if we did so well with the MDGs, can we do better? And can we now do something for the entire world, not just low and middle income countries? And that's how, ladies and gentlemen, the concept of sustainable development goals were born. So from 8 Millennium Goals, we went to 17 Sustainable Development Goals, and this was one of the most informed and most well-debated process of setting global targets that at least I've ever seen. 2 साल committees, agencies, regional groups. They spent all that time debating what could be done or not. And I think they went a little overboard because from 8 goals, which were very focused, we had 17 goals. Some of them could not be even measured very well, and around 300 indicators for progress. And people thought that this would be very difficult because these were goals for every country. But they were signed into a global compact in September 2015. And we are today at the halfway mark of these SDGs. That's why I'm speaking to you on this subject. These Sustainable Development Goals united every country in the world. They're just as relevant to Canada as they are to, for example, Pakistan or Africa. And they are aspirational goals, but they have health, once again, at its very core. So when you look at the health and health-related Sustainable Development Goals from these 17, they relate to many things that are direct and indirect contributors to health. So many of you may have heard the term social determinants of health. So health in any given population. In Canada, the health of the indigenous population is totally dependent upon deprivations on where they are, who they are, their history, where they live, what is afforded to them in terms of social capital. Similarly, in low and middle income countries, health is completely dependent upon your living conditions, your background, where you are, ethnicity, marginalization, conflict, displacement, people on the move. So these social determinants of health are just as important to services that are available in hospitals or in primary care. So the way we look at this, at least for health and health-related SDGs, they are overwhelmingly aligned around 5 concepts of people, planetary health or the living conditions, poverty alleviation or prosperity, peace, absence of conflict, and partnerships. And health, therefore, at least to health professionals who are working in SDGs, is very much around the center of these SDGs. So let's, for a moment, look at what these core health and health-related sustainable development goals are. And I'm going to be very high level because I just want you to understand what these goals represent. So the first goal, goal 1, is about eliminating poverty in all its forms everywhere. In the MDGs, it was all about extreme poverty. The SDGs went beyond it to say we will eliminate poverty in all its forms. Goal 2, which is a separate goal, is around ending hunger, eliminating severe malnutrition, and ending extreme hunger in all its forms. There is only one goal for health, unlike the MDGs, where there were several goals for health. It's only one goal for health, and it's an all-encompassing goal. It is ensuring healthy lives and well-being. So it's no longer about survival. It is about how do you thrive? How do you have a healthy life course for all populations? And what delighted many of us was that we introduced, as part of this, a very important sustainable development goal which underpins health, which is education. Inclusive and quality education, goal 4. Goal 5 is on gender equality and empowerment for girls and women. Extremely important for many geographies, including our own homeland. Access to safe water, sanitation, goal 6. And ensuring that everybody everywhere has access to this. You see, we're very fortunate in Canada. You have over 1/3 of the world's clean, fresh water resources. That's worth its weight in gold, actually more powerful than oil. And in a country like Pakistan, where we are on the verge of water scarcity now, you realize how the world is also unequal when it comes to advantages. So ensuring access to safe water and sanitation for all is goal 6. Reducing inequities between countries. And importantly, I think people were way ahead of their time. In 2013, when committees were established to look at these goals, they put in goal 13. It came way down the list, but the goal 13 was to look at climate change. We live in 5 epidemiological zones of Pakistan. There's a story of 5 Pakistans. And you can see this very clearly. And I'm going to rapidly go through these maps and show you how, for many things, related to family planning change, to antenatal care, to skilled birth attendants, to fully immunized children, to oral rehydration therapy for diarrhea, to care seeking for pneumonia. Each one of these, there are parts of Pakistan where care to those who have the money is just probably as good as you would get in Vancouver. And there are others where care standards and coverage is probably even worse than parts of Africa. So ये जो 5 epidemiologies हैं, this is the basic fundamental reason why investments need to be made to bridge that gap, to bring people together, to deliberately invest in backward areas, those people who have nothing in many rural populations and no access, so that you can reduce that gap between the haves and have-nots. Now, this is politically and philosophically challenging for many people because there are many people in power, in policies. You worked with General Musharraf, so did I. Our biggest problem with his prime minister at that time was a banker, a financier, was that he believed very strongly that trickle down, that as you improve the lots of the country, GDP per capita income, the benefits will accrue to the poor. In an egalitarian society, that may happen. But when there isn't an egalitarian society, then what you get is what you're getting in India now, that you have people who are able to spend $700 million on a single wedding in a country where 40% of the people are below the poverty line. And the same happened in Aziz's time in Pakistan, is that GDP per capita income went up. He was very proud of the fact that we were selling cars and we were producing motorbikes. And yet the poverty, extreme poverty level and inequity did not change. So it's extremely important to keep tabs on this from this epidemiological perspective. And the last challenge that I'm going to talk about before I change to what can we do to make a difference is really the whole issue of conflict and insecurity. I come from the Northwest Khyber Pakhtunkhwa province myself. So I can tell you, and I work in provinces of Balochistan and KP and Fata areas now called the newly merged districts. I can tell you that this is the big issue right now. We looked at this systematically a few years ago in Balochistan, where we compared the coverage rate of interventions in secure and insecure areas and extremely insecure areas. And the difference was chalk and cheese. That people living in insecure areas or areas affected by conflict had virtually no access to services. And you can see this, if anything, through the marker of what you have currently in immunization and polio control programs. So if you look at this clustering of conflict that we did at that time, battle-related effects, and look at polio distribution, polio was clustered largely around your insecure areas. And the same is true today. That in the Afghanistan-Pakistan region, much of this disease burden is clustered around insecure areas. So peace and security, absolutely essential to get a change. All right, now I have depressed you enough in the last 20 minutes, so I'm now going to give you some good news. All of this is a challenge. And all of this can change, and can change at scale. And I'm not talking about small projects. I'm going to talk to you about where change has taken place and is taking place as we speak, just to give you hope that, things can change if you want to. So for each of these areas, let me give you examples. The first tough example I gave you was of stunting. Now, yes, stunting is ubiquitous, is common, but stunting can also change. And it changes between different provinces. So this slide shows you how stunting rates have changed in different provinces. And yes, they have been very slow. But look at this dark blue line, where rates of change of stunting have been about 3% per annum per year over the last decade. And guess which province this is? Ashwat, you get full marks to guess where this change in stunting has taken place. It's Khyber Pakhtunkhwa, one of the poorest regions of Pakistan. And you don't believe the figures, you can believe the geospatial estimates. Punjab, northern Punjab in particular, and KP are the two provinces. We have these data coming out in a month or so. they have reduced stunting rates at the same level as one of the best country exemplars. And we were very interested in. So we did a decomposition analysis to say, कि कैसे हुआ कैसे? Because the amount of money that people have put in is about the same. Maybe Punjab has spent more. But KP is one of the poorest provinces. Why did this change? What changed? And of the drivers that you have for change, don't go through this complex analysis. I'll tell you two major factors in the change of stunting rates in KP. One is economic improvement, which happened, but economic improvement not just across the board, particularly for women. And the one program that has contributed to a third almost of all of this change in stunting is the Benazir Income Support Program. Does anyone know why? Because the money goes to the woman of the household. The woman head of the household gets the money. Maybe even the man takes the money away, but she still gets something. So that is a huge driver of change. When people wanted to kill the Benazir Income Support Program, I had to stand up and say, don't be crazy, don't be idiots. This is the one program that is empowering rural women, and you have demonstration of that. That even though the money may be going on one thing or the other, etc., buying goods, but it is translating into food security and better nutrition for their children and for themselves. So yes, it can change. More good news on a more difficult area. Can newborn mortality, which has been so bad in various places, can that change? And whenever I used to take this to the government, they would say to me, Dr. Saab, aap hame ye Matiari ka data na bataएं, अपने district का data ना बताएं. Tell us what can happen at scale. So in 2016, I persuaded the Gates Foundation to give us $25 million to work out what could be done at scale for mortality reduction in rural Pakistan. And to do this, we selected 10 districts with the highest mortality rates in the country, with the engagement of the government, province of Punjab, Sindh, and Balochistan. And these 10 districts represent a population of about 10 million. And this project that was developed is called Umeed and New Hope Project, was designed and implemented through the government. It wasn't my project, wasn't anybody else's. It was a project implemented through the Department of Health and the Lady Health Workers Program. And we recently finished the analysis of this project, and what it shows you is that overall, mortality reduction in these districts, worst districts of Pakistan, for newborn mortality reduction has been close to around 27 to 36%. This, in comparison, is about 3 times as fast as the secular trends in mortality reduction for the rest of Pakistan. So it can be done. And not only can it be done at scale, it can be done sub-district wise also in reducing the differentials and gaps. So वही जो मैंने आपको शुरू में मुजफ्फरगढ़ का डेटा बताया था, guess what happens to mortality differentials in one district. Let me show you Badin district with differentials in newborn and child mortality. The beginning, middle, when there were floods, and at the end of the project, that you can have that differential disappear. You can also have inequities that go down, and in some of the most difficult areas. So I'm only going to give you one example of working in conflict areas and conflict zones in terms of what can be done to reduce inequities and gaps. So this 146 union councils of the 10 highest risk districts of the country in Sindh, Khyber Pakhtunkhwa, and Quetta block represent where the bulk of the immunization gaps and polio clustering was. And here, this was implemented through partnership with the community engagement, the Lady Health Workers Program, and the results were phenomenal. We were able to see improvements in immunization rates up to 90%, routine immunization rates going up significantly before the beginning and end, and importantly, reduction in the inequities and the gaps. So if there was the gap at the beginning, the difference between the poor and the rich, just look at what happens towards the end. That you have a significant reduction in the equity gap in those children who are unimmunized. And even amongst the fully immunized children, although we were not able to achieve this gap reduction in Balochistan and Punjab, but Karachi, we were able to almost eliminate those inequities. Now, I know I'm taking an extra couple of minutes, but I do want to talk about governance and democracy, because this is for the young people in particular who see only Pakistan through the lens of bad news, a very important area. So some 20 years ago, I did this study of mortality in the Islamic world in Eastern Mediterranean region. And I looked at the relationship, it was a chance finding, of governance and child mortality. And it was very evident looking at the small data set that there was a close correlation between poor governance and high child mortality rates. We recently revisited this for Islamic countries, and that correlation, if anything, is extremely strong. So इसको अगर आप पाकिस्तान के लेंस से देखें, so one thing that we've been all very interested in is looking at when have government policies been pro-poor? When have government policies focused on reducing the gaps between the rich and the poor? Which eras? And in the 70 plus years history of Pakistan, we've had all kinds of governments. We've had democracies, autocracies, kleptocracies, and we've had straight military rule. Okay? So we're able to do this. And if you go back to where the actual pro-poor policies were in health for women and children, it is very clear that some of those seminal programs that have reached the poor were only developed during periods of participatory democracy. The Lady Health Workers Program in 1994 was developed by Benazir Bhutto, who came back from Cairo and wanted to do something for poor rural women. Similarly, at other time points, the income support program was developed to target poor women in rural areas. May have taken its time in terms of maturity, but yes, the health insurance program, one of the most remarkable health insurance programs, was done in a democracy in Khyber Pakhtunkhwa at scale. And ठीक है उसमें, there may have been issues, but it made a huge amount of difference. That they could politically not stop it. They stopped it, they had to put it back in some shape and form. But the one thing that people criticize enormously is the 18th Amendment, is devolution. Why did health go from the federation to the provinces? That also happened in a democratic time, but through a democratic, thoughtful process. So did the 18th Amendment make a difference, or did it reduce, the efficiency of the health services? So we've looked at this in the context of the 18th Amendment and its impact on child immunization rates. And the red lines represent the post-18th Amendment period in terms of coverage of full immunization rates and change. And these odds ratios are the proportions, let's say, of improvement in full immunization rates. So when it says 2.8, it means almost a threefold increase in full immunization rates. Nationally, for Punjab, it's fourfolds. For Sindh, it is almost 4 to 5 folds. And for Khyber Pakhtunkhwa, is almost 2 folds. And for the worst possible province, Balochistan, where insurgency and lack of health system still means there's a big challenge out there, even in Balochistan, you had about a 3-fold increase in child immunization rates. They still have a challenge of about 30% rates, but that challenge is doable, is addressable. So let me finish by giving you my perspective on SDGs in Pakistan. And I'll say something about what can we do as APPIC. So first of all, there is still very limited awareness of sustainable development goals and health and development in Pakistan. Very few policymakers, other than the fact that they see the official reports, are able to comprehend these in their entirety as to what they are and what do they represent. We cannot achieve the SDGs at the pace that we are going, and it really needs acceleration in the very worst areas with targeting of the populations who need it most. And this has to become central to the development agenda. At the moment, our development agenda is all around increasing energy sufficiency, reducing poverty, addressing our debt, and surviving. And no country can ever survive with a Band-Aid solutions, which is only short-term. So we really need to be looking at what do we need to do for the next 20 years, 30 years. Inshallah, nothing will happen to Pakistan, but we cannot survive in this patchy band-aid mode. We have to go to hardcore decision on what the country needs to do to invest in long term. And it has to be focused on reaching the marginalized population. You have seen what happened in other geographies. You have seen how people have risen in Kenya, in Bangladesh, young people. You cannot achieve development goals with unemployment rates of 70%. Which area of Pakistan has unemployment rates of 70%? Balochistan and FATA and your newly merged districts. There are no employment opportunities. When young people have no employment opportunities, where do you think they will go? Well, they will go to big cities or they will rise up in arms, which is what happens. So I think this is a huge opportunity for the Pakistani diaspora to get engaged in Pakistan, for not just yourselves, for our children, actually. Our children who need to be linked to their motherland in some way. This is an opportunity for them to contribute just like any other nation in the world does. So what is it that APPIC can do? And I'm not an office bearer, don't want to be. I can only give you my opinions on this as to what physicians in Canada who want to work on issues of Pakistan can do. My first message to you is, you can't do this without engagement. Okay. You may not get involved, but you have to get engaged and informed. So just keeping on top of what is happening, understanding it, analysis. I speak to so many people who said, "वो पाकिस्तानी खबरें आती हैं, मैं switch off कर देता हूँ. I switch off. I don't want to listen to bad news. I don't read this. मैं खबरें नहीं सुनता हूँ." Don't do that. I mean, you find your own information sources, but stay engaged, because without information, you can't do anything. There is a lot of good going on in the country. I've just given you some examples of stuff that my group does. And this is not just based at Aga Khan. This is also based in Canada. I run a group of 50, 60 scholars actually work on Pakistan issues from Toronto. Join hands with the people who are working on the ground. Citizens Foundation, Child Life Foundation. Nasir Mahmood, I wish he was here. He runs the Child Life Foundation. He's based in Toronto. I mean, that runs all the emergency services in many parts of the country, actually. There are thousands of people who are doing this. Citizens Foundation raises 70 to 80% of its funds for its schools from outside of Pakistan. Right? Start small. Start with a few small initiatives and build on it. Don't be so aspirational कि आप बिल्कुल pie in the sky की तरफ चले जाएं. Partner with those who are engaged in this work, particularly around research. And I'm deliberately to this audience saying, you have a lot of young people, you have your children who are in med school, your children who are studying. There's a lot of implementation work going on in this issue, in this area, in Pakistan, with people who are engaged in this. I mean, link up to them. Don't do things on your own. Lots of people do individual charity, you can do it, but on this, being organized is a lot better. And finally, don't lose hope. As I've said, people, when they become despondent, they react in one or two ways. I mean, one of the ways that I've seen people react is, they say, it's gone, done. When was the last time you went to Pakistan? 7 years ago. Don't do that. You see, आपको अंदाजा होता है वतन का और वतन की मिट्टी का जब आपसे वो छिन जाती है. Right? You have to just look around yourself and see what a motherland means to people and what it means not to have a homeland. Okay? So engaging, no matter how difficult it is absolutely essential. And it is important for you to know that you have to differentiate between people who are in power, governments, and the people of Pakistan. दोनों में ज़मीन आसमान का फर्क है. The people of Pakistan are the hardest working people that you can imagine. They are the salt of the earth. They are not the politicians or people that you see on the tube or on the news. They are the people who work hard in the background and keep the country afloat. They are the people that you see in these images who work day and night, sometimes doing 3 jobs a day just to put bread on the table. A lot of people turn around and say, why aren't people rising up in arms in Pakistan with so much inflation and so much poverty? It's because people work hard to survive and they've got their heads down and they're working. These are the people who are the real people of Pakistan. And this is the reason why a man from Mia Channu. How many people know where Mia Channu is? Only those people who travel by train know where Mia Channu is. This man who could not even afford to buy a javelin, okay? I mean, if this man can beat the Olympic records, then it tells you that the average Pakistani is the salt of the earth. So don't lose hope in the country. Why? Because hope springs eternal, and it gives everybody, including your children, my children, a reason to be engaged. So I want to thank you for all your attention.